Thank you, everyone, for joining over lunchtime today. I'm Simon McPherson. I'm one of the NCEPOD clinical coordinators. We are holding this webinar to mark today's release of a balanced solution in which we reviewed the hospital care of patients with hypo or hypernatremia. We're firstly going to hear from Dr. Helen Simpson as to why the study was needed. Then David Wood and I will give the highlights of what we did and what we found. And then we will finish with Dr. Alistair Scotland, speaking as a patient, telling us what impacts he hopes this report will have for future patients. I'll now hand over to Helen.
Thank you for inviting me to present and introduce this really important topic. So this is me, and as well as being a consultant endocrinologist, I'm part of the Royal College of Physicians Patient Safety Committee. And I'd like to illustrate with some clinical cases. So this was a 35-year-old woman I was looking after. She was unwell, uncooperative in the emergency department, history of a viral upper respiratory chest infection, and was drinking large volumes of liquid cough medicine. She was seen on the post-take ward round with a sodium of 120 and was given a litre of 0.9% saline rapidly, and she promptly had a seizure. She dropped her sodium to 113, and you can see she had a very high urine osmolality and a high urinary sodium, and this gave a clinical diagnosis of syndrome of inappropriate diuresis and excessive vasopressin, wasn't excreting a free water load. We gave her, she was intubated on intensive care, had hypertonic saline, and you can see self-corrected, and we decided this was related to medication, self-corrected a day later, sodium normalized and has been well since. But you can see the impact here of giving 0.9% fluid in hyponatremia. It's hyponatremia is the commonest electrolyte abnormality, and we get particularly worried in the inpatient setting for moderate or severe hyponatremia, causing confusion, altered state, and extreme situations, seizures, coma, and death. There is a diagnostic algorithm. Hyponatremia is like anemia. It's not a diagnosis. It's a symptom, if you like, and we advocate doing some investigations to work out the cause, because then you can work out the treatment. And it's really a disorder of water, not salt. And you can see that people can drink too much water. There can be conditions such as heart failure, third spacing, or SIADH, head injury, and some drugs that can cause issues. And there's algorithms hopefully available and some references in this report to help people manage hypertonic saline. The other end of the spectrum, severe hypernatremia, severe high sodium, is also challenging with severe harms and deaths. We see this in particular people with cranial diabetes insipidus or AVP deficiency, and drugs have been omitted in the inpatient setting, and there's a very tragic story of somebody not giving their desmopressin, required to call 999 to get water in hospital, and sadly died. The hospital accepted responsibility for this death. We've had a similar incident at UCLH, so it's not a single hospital occurrence. And again, here our patient was not given desmopressin for 48 hours, had a sodium of 191 and went to ITU, but thankfully did survive. In terms of cranial DI or AVP deficiency, there has been a national patient safety alert, but unfortunately this hasn't changed, particularly in the instance of harm from a very high sodium due to drug omission. So as you can probably tell, sodium management is one of my hills to die on, and really we need to think about why this is. We need to think it's a water problem, and you can see my hill here with some water. And we know that deaths are still and severe harms are occurring due to management as well as the condition itself. And I'm really grateful both to the Royal College of Physicians Patient Safety Committee listening and putting this forward as a topic for NCEPOD. And I'd be really grateful for everybody on this call can share this report with their teams. And as I say, also like to thank the team for working on this and look forward to hearing more over the next hour or so. Thank you.
Thank you, Helen. So what we did and what we found. I'm just going to briefly tell people where the data came from, and then David's going to take over the rest. So the study population was from the last 3 months of 2023, and we identified patients with hyponatremia or hyponatremia during the admission. We included patients who presented as an emergency and those who developed abnormal sodiums, principally after surgery, whilst in hospital for surgical admission. The data comes from 3 principal sources. We had 640 clinical questionnaires. Just under 500 of those were for hyponatremia, showing that it's more prevalent, and 142 for hypernatremia. We had 419 sets of case notes reviewed against a standardized electronic questionnaire in the offices in London by an expert group of reviewers, and 156 organizational questionnaires were returned. David.
So thank you very much. My name's David. I'm one of the NCEPOD clinical coordinators here, and I'm going to take you through some of the key recommendations from the report and some of the data that we found doing the case note reviews. And first, I'd like to thank all of those people who are involved, both the local reporters for supporting the study, the local clinicians who completed the clinician questionnaire that Simon mentioned, and then the reviewers who came to the office and did the detailed case note reviews, and also the support of the study advisory group and the other experts who helped formulate the study and do the work with us. So as Helen mentioned, abnormal blood sodium is the most common electrolyte abnormality. And in the 3-month study period, although we only reviewed a small number of cases, there were around 42,000 patients with hyponatremia and 7,000 patients with hypernatremia coded on their hospital admission. So it's a very common medical condition. An appropriate and timely investigation to identify the cause and therefore guide the treatment is very important, because that can prevent worsening of the hypo or the hypernatremia and also prevent complications from the treatment that we're doing. One of the difficulties is that these patients will often present out of working hours when specialists and senior clinicians may not be present on site to help guide the investigation and management of those patients. And therefore, our first recommendation was around the consideration of developing care bundles and training associated with those to reduce the variation in the assessment and management of abnormal blood sodium levels. As Helen highlighted, there is a guideline from the Society for Endocrinology, and there are other guidelines both available nationally and internationally for the assessment and management of blood sodium when it is low, but there aren't similar guidelines for when patients have hypernatremia. We also identified in our case note reviews that nearly 50% of patients with a low blood sodium required additional investigations done, which weren't done during their initial assessment. And actually, that was more common in those patients who had post-operative hyponatremia, often because clinicians will assume the cause is related to fluid balance or fluid being given insufficient fluid post-operatively. I'm just going to highlight some of the areas where we identified some areas where development of a care bundle might help to improve the investigation of patients. Most patients have imaging, so x-rays or other imaging done when they're admitted to hospital, but actually we identified that rarely that impacted on management. And what is more appropriate is ensuring that investigations are targeted to the potential causes for hypo or hypernatremia. As we highlighted in the extended report, there was a case study where an individual who was high risk because of being a long-term smoker presented with hyponatremia, did not have a chest x-ray done, and presented later with evidence of lung cancer and metastases, which could have been diagnosed at an earlier stage and allowed intervention from that point of view. In terms of other investigations, the measurement of blood cortisol and serum and urine osmolality is very important. NICE guidelines and the Society of Endocrinology also talk about measuring the timing of measuring of cortisol, but ideally should be done between 8 and 9 a.m. in the morning. But only about 20% of patients had their cortisol measured during that time, which may mean repeated investigations have to be done, or clinicians may misinterpret those results if they're very high or very low. Additionally, getting paired serum and urine osmolality is often challenging. It's difficult to obtain urines, and we're more able to get a serum osmolality available within 50% were done within 3.5 hours, whereas for urine it took nearly 9 hours to get a serum osmolality available. And often clinicians need those to help interpret them, but also we need some better guidance for when clinicians do interpret those. And Helen presented a case at the start, someone had a very, very low sodium, where they were given inappropriately given intravenous fluid. And we do know that there were cases we reviewed where patients had very low serum osmolarities and were also given intravenous fluids. We know from other areas of medicine that the implementation of care bundles, such as in the management of sepsis, improves the timely investigation and management. And therefore, our recommendation was to try and develop these care bundles to help guide resident doctors and other clinicians in the initial assessment and management of patients. If we'd like to move on now, we now going to consider the second recommendation, which was around improving the clinical assessment of fluid status in patients presenting with hypo or hypernatremia. Now, in our study, the majority of patients had hypotonic hyponatremia, and often clinicians will then undertake an assessment of fluid status to help with the diagnosis to determine whether the patient is hypovolemic, euvolemic, or hypervolemic. As I mentioned, many patients present out of hours when resident doctors or less experienced clinicians are on site, and even for experienced clinicians, undertaking an accurate fluid assessment can be challenging. The NICE guidance for the management of hyponatremia highlight the importance of fluid assessment in the initial assessment of a patient with hyponatremia. Other guidelines are conflicting on whether fluid assessment needs to be done as part of that because of this challenging difficulty. We'd identified that only about 40% of patients who presented with hyponatremia had an appropriate fluid assessment done on admission, and that may impact on the determination of the cause and therefore the treatment that was offered for those patients. We've talked about point-of-care ultrasound, which is becoming more widely available and used for a range of different medical conditions in their assessment in emergency departments and across hospitals. In our study, we identified that very few patients had point-of-care ultrasound undertaken. Existing guidance currently doesn't refer to the use of point-of-care ultrasound in the assessment of fluid status for hypo or hyponatremia management. And that's partly because this was not widely available when those guidelines were put in place. So it's potential that if point-of-care ultrasound training is put in place, that may help in the initial fluid assessment alongside with clinical assessment in determining the true fluid status of a patient and what treatments may be required. In addition, fluid assessment and fluid balance management is not a single one-off assessment on the time of admission, but often patients will need repeated assessment of their fluid status to guide ongoing treatment or determine if alternate treatment is required. One part of that is accurate fluid balance management. Documentation of fluid balance is often done poorly within hospital because patients often don't have what they've drunk documented, or urine output is not widely documented. We did demonstrate that if you look at patients who present with hypernatremia, only 27% of those had their highest blood sodium on admission, and many patients deteriorated because of poor documentation around fluid balance, so that clinicians were not aware that they had reduction in their fluid input and therefore could have treated them with intravenous fluid. So therefore, we would recommend improving the clinical training of individuals to do accurate fluid assessment and also improving fluid balance management and documentation. Next slide. So the next thing we wanted to highlight was about the integration of near-patient testing into patient electronic records to help identify trends in blood sodium levels. So we've demonstrated in our case review that about 25% of patients had a delay in the treatment of their initial hyponatremia. And part of that is because early identification of a low blood sodium is needed, and that requires an early blood test to be done. Now, we demonstrated that only about 50% of patients had a blood sodium level available within an hour of presentation to hospital. That increased to around 75% of people who present within 2.5 hours of presentation to hospital. We know that numerous bodies, such as the Royal College of Pathologists and NHS England and NHS Improvement, have talked about turnaround time in terms of getting results for blood sodium and other electrolytes available within an hour of patients presenting to hospital. However, there are many parts where there will be delays in the pathway in terms of getting that blood result. Firstly, in terms of sample collection time from time to presentation to when the blood sample is taken, delays in getting the sample to the laboratory where the analysis is undertaken, any potential delays in getting the sample processed, analysed and reported, and then finally the clinicians acting on the result when it is available to them. Now, many of us who work in hospitals will know that most patients, when they present to an emergency department or a medical assessment unit, will have a point of care blood gas done as part of their initial blood tests. And that is available much more rapidly to individuals treating that patient, and the majority of those will include a blood sodium. Clinicians often don't rely on the blood sodium on a venous blood gas result and would wait for the laboratory result to come back, which may take an hour or longer. And we noted that from the clinician surveys, the majority of patients, the initial sodium was actually reported to be from a laboratory sodium rather than a venous blood gas. And that's possibly not because the blood gas wasn't done, but often the blood gas result may be a printout that may not be then stored within the notes, so you may not be able to refer back to it during the admission or on subsequent admissions, or clinicians may not enter all of the patient identifiable information, so therefore you cannot integrate it into the laboratory systems. We had a case study we had highlighted where someone presented with a sodium of 109 on a blood gas. The clinicians didn't act on that, and by the time the laboratory result of 114 had phoned back, which is fairly comparable, the patient had already had a seizure that may have been prevented if they'd acted on the initial venous blood gas result. So although some blood gas analyzers are integrated into electronic laboratory reporting systems, this needs to be more widespread, and that will allow better reporting of trends and allow laboratory staff to also identify what is happening outside of the laboratory itself. If we move on, Helen mentioned in the case that she presented about the use of hypertonic saline. And there were the NICE, the Society for Endocrinology, and other European international guidance refer to the use of hypertonic saline for patients who have moderate or severe clinical features of hyponatremia. We showed that on review that about a third of patients where they were given hypertonic saline as part of their management, there were issues in its use, either in terms of the dose, the route of administration, monitoring, or the decision to actually use the treatment. Only a small number of patients actually had hypertonic saline given. So we identified that 55% of those who were reviewed were given hypertonic saline. But on more detailed review, about 7 of those actually didn't require it because there was no clinical evidence of moderate or severe hyponatremia, but were treated on the basis of biochemical hyponatremia features. In addition, there were another 19 patients who had moderate or severe documented clinical features of hyponatremia that weren't given it. So we have difficulties there in identifying patients who should be given it and patients who are given it inappropriately. The guidelines currently all refer to the use of 3% hypertonic saline, whereas actually in most hospitals only 2.7% hypertonic saline is required. But a significant proportion of patients are also given 1.8% hypertonic saline, which may mean they require larger volumes of it to be administered, which may then have an impact in terms of fluid balance. We also know from a 2019 IRIS study from colleagues who are involved in the study advisory group that bolus administration of hypertonic saline is associated with a better improvement in both sodium concentrations and clinical features such as level of consciousness. However, 40% of patients in our study were only given intravenous infusions of hypertonic saline rather than being given boluses as would be recommended. And then finally, we need to monitor patients to prevent overcorrection from hypertonic saline. Too rapid correction or overcorrection increases the risk of osmotic demyelination syndrome. Whilst this is rare and we didn't have any cases in our study, this has been widely reported in patients where overcorrection or too rapid correction occurs. Most hypertonic saline was administered in a level 2 or level 3 environment, so either a high dependency or critical care environment or an emergency department resuscitation environment. But following administration, there needs to be careful monitoring of that patient ideally within a level 2 or 3 environment, to ensure that overcorrection doesn't occur, and if it does, that it is appropriately managed and identified. However, where hypertonic saline was administered in an emergency department, only a proportion of those were admitted to a level 2-3 area for ongoing management. There were a small number of patients in our study who did develop overcorrection of their sodium. As I mentioned, none of them went on to develop osmotic demyelination syndrome. However, a significant proportion of those patients who did develop overcorrection, this was potentially avoidable because of a lack of monitoring of blood sodium. We did highlight in the full report a case of where there was a very good recognition of severe hyponatremia. They had a local guideline which outlined the use of hypertonic saline and had specific criteria for the monitoring of blood sodium after administration and how to monitor and manage overcorrection should it occur. So whilst there is guidance around the use of hypertonic saline, we feel that this needs to be better improved to help with the clinicians who need to treat patients with severe or moderate hyponatremia. The final recommendation was around changes in medication. Now, many of us will be aware that medications we prescribe to patients are a common cause of hyponatremia. And over 80% of patients that we reviewed who were admitted with hyponatremia were taking one or more medicine that could be associated with or the cause of their hyponatremia. And for those, a majority actually had a change to their medication, that may be stopping it, a change in dose, or substitution to another alternative medication, which may be less likely to cause hyponatremia. The commonest thing we did was we stopped medication, so the cause of medication had been stopped by the treating clinicians. However, stopping medication is not without risk, and often there isn't clear documentation of the risk-benefit assessment that is undertaken. For example, if someone is on an anticonvulsant that could be associated with hyponatremia, inappropriate stopping may actually increase the risk of the individual having a seizure, which may be worse than the potential risk of the hyponatremia associated with that medication. Although there was evidence that there was communication to the general practitioner looking after the patient that there had been a change, the most common thing was the omission of the medication from the discharge letter rather than documentation about what the change was and why that change had occurred. This increases the risk to the patient because the GP may think the admission is an error and the medication is not being included on discharge, and then restart not noting that it is due to hyponatremia that it's been stopped. Additionally, we need to be better at counselling patients about the changes we've made to their medication. Many of our patients will have stockpiles of medication at home. They will go home and start reusing the medications they were on before they came into hospital. And we need to be clearly explaining to them why we've stopped the medication and why they shouldn't restart it. And as we highlighted in the report again, there was a case of someone who had hyponatremia, they had seizures, and there was specialist neurology input to consider the changes in medications required to make sure they didn't have a recurrence of their seizure. And that decision around the changes was clearly communicated to the general practitioner so they were aware not to restart that medication. I'd now like to hand over to Dr. Alistair Scotland, who's going to give us the patient perspective from this report.
Thank you very much indeed. I will not speak for long because we've heard what is the important aspect of the whole report. The reason I'm sitting here is quite straightforward. About 2 years ago, I had a sudden, out of the blue, acute episode of profound hyponatremia. And that meant that over 36 hours, I went from being completely fine to feeling desperately ill, almost unable to stand, let alone walk. And by the time I actually got to hospital, I was starting to lose my sight. It worked out well for me because the receiving acute physician team specialized in metabolic medicine. And so there was an assessment right away, and the treatment was put in place right away, and all worked out well. So not surprisingly, what I'm looking forward for is really in two groups. Firstly, that there is a sufficient index of suspicion to get on with identifying the problem, and then to put in place in a timely way the safe management according to proper guidance. And the second group is to get on with finding out why it happened so that as far as possible, recurrence can be prevented. Both of those happened with me. The only other comment I would make is that an episode is very frightening for the patient. There's an awful lot of activity around the patient dealing with an acute episode to prevent what we've heard about. And so communication throughout, even if the patient looks very far from being fully conscious and alert, they may well take in what you're saying. It's really important to keep them informed, to keep them up to date with what's happening. And really honestly, we've heard from the report that what I'm asking for is covered. So if it is put in place, we should be in a much better position not to see the very profound outcomes that we can. Thank you.